Okay, that sounds great. Thank you, Jolene. It's a pleasure to have this chance to talk with you all today. My thanks especially to Dr. Pritchett and Dr. Michaels for inviting me to partner with the SERPA ACO for the first of what we hope will be planned to be a series of conversations about value-based care, quality, and operations topics. Today and the next time we get together, we'll want to talk about risk. What is it conceptually and practically? How does it figure into Medicare's plans and financing? And how can we manage and even harvest that risk for the benefit of our patients and our practices? Let me pause there and just ask Jolene, is that volume doing okay?
I can hear you fine, thank you.
All righty, very good. And I don't have presenter controls. If you can pass them back. Oh, there it goes. Okay, so first of all, just introduce myself. I'm a medical director at St. John Clinic in Tulsa. I've got responsibility over primary care operations at 32 sites, about 120, actually closer to 130 now, physicians and mid-level providers. I lead St. John's CPC and soon CPC Plus endeavors. I have responsibility for population health and quality improvement, as well as coding and documentation.
Did you talk at that ICD hearing conference in Memphis?
I previously served as medical director and was on the board of the ACO in Wichita. Issues as chair of the Commission on Quality and Practice now twice over the last decade. I've been a member of the Academy's RUC team going on now more than 12 years, and have been through the Kansas Academy of Family Physicians as president, board chair, delegate to the Congress for multiple years. As we approach this, realize that to me, I believe that everything can be improved. Nothing is perfect. So we are all working very hard for our patients all the time, but we can still always do better. Striving to improve the health and life of our families and practices and communities is what brings all of us meaning, and that serving others is our highest calling. And so that's kind of the attitude I take to this. And I see this as trying to serve you all and your patients. And so if you have comments or suggestions of how to do that better, then I certainly want to hear them. And in general, realize that our history is just a tapestry that we bring to our engagements. And these are some of the parts that make up my tapestry as a colonel in the Army and long-term care medical director and a dad and a wife and all of those things. You all each have those elements of your tapestry that you bring to your patients. Lastly, I'll just say by way of introduction that I greatly enjoyed my 4 presentations in Nebraska with the Nebraska Academy of Family Physicians back in 2015. I am proud to know and consider both Joe Miller and Bob Worgan good friends and colleagues, and I appreciate this further engagement. So with that, we'll get started and kind of take a look at risk. So in general, risk is like a fire. If it's controlled, it can help us. We can use it to do amazing things. But if uncontrolled and not understood, it will rise up and have dramatic consequences. So this is our agenda. Today is part 1. We're going to talk about just a welcome introduction, which we've done, and an intro to risk and risk adjustment, and then explore and really kind of try to get to the underpinnings of the Medicare HCC system. Then next time, at a date still to be developed, and we'll figure that out in the near future for you, we're going to get a little bit more operationally and tactically focused and talk about RAF scoring works in practice, try to dispel some myths about that, and then discuss ways to really make it work for your practices and for the SERPA ACO. So any questions, you can, I think, enter them in the chat box, and I will try to address them as we go, and then we will have time for questions at the end as well. So let's get started. First thing to say is when you think about CC risk scoring, many of my partners really just decide that it's too hard and they don't want to know it. And what I have to say is every one of you on the phone was a master of the Krebs cycle at some point in your career. So what we're talking about today really is much, much easier than things we've learned and mastered. But this is not Greek. It does have an internal logic that's learnable and understandable, and that language analogy is really useful because understanding and learning how the language and the math of Medicare risk flows through healthcare is similar to learning some rudimentary French for a trip to Paris. It makes your time there, gives you greater appreciation, you're more functional in day-to-day activities, you're able to speak some and exchange ideas with the natives of that land, and you're less likely to be taken advantage of. All of those elements ring true, learning the language of Medicare risk scoring and how to use that. But I do have to say there isn't a miracle. We can't just download the knowledge. We just have to dig in, and so we'll do that. First of all, risk adjustment is conceptually, it's a way to compensate for differences among patients that affect outcomes. And those differences can be demographics, as simple as age or male-female. It can be illnesses, which can be expressed as diagnoses or lab values or other code sets. There are increasingly, we understand, differences in socioeconomic factors in medicine that affect health outcomes, and some of those are captured in risk adjustment systems and some are not. Another way to think about risk adjustment is it's a method of making what we intuitively or clinically know about a patient more objective and measurable. And partly that's just a function of language. If we can't define something and use a common term to describe it, we're not able to communicate, and you can't measure or improve it. It's also hard to act on. You know, I think all of us could think of the 6 patients in our practice that we would not be surprised if they had passed away in the next 6 months. That's one very real definition of patient risk. But to be able to affect that and manage it, we have to define it a bit more than that. The other thing to think about risk is how payers approach population health, and we'll discuss that analogy a bit more. So the basic purposes for risk adjustment is that it levels the playing field and lets you compare patients to patients equally. Now that could be processes, such as utilizations or discharges. It could be a utilization measure like cost. Cost is only a relative measure from patient to patient if you're comparing patients as apples to apples. If you're comparing the cost of a 30-year-old healthy female with no health problems or medications and an 80-year-old gentleman with cancer, those are not equal comparisons. And therefore the dollar figures for each are not useful for you. Risk adjustment allows fair allocation of funds for treatment. So remember, prior to 1992, payment in healthcare financing was done under the usual and customary system, where Medicare defined that a visit in New York City was usually and customarily a certain price, and they paid a fraction of that. And in Lincoln, it was a different usual and customary price, and they paid a fraction of that. And none of us liked that system very well. In 1992, we moved to the resource-based relative value system, which pays us based on the inputs, the costs of providing a service. And therefore, the very foundational underpinning to our current financing system depends on those inputs being accurate, and that accuracy is only true if risk adjustment is accurate. Lastly, risk adjustment does encourage us and rewards complete and accurate diagnosis and coding, and it is a way, both at the provider level and the payer level, to discourage adverse selection. Now let's think about how this concept of risk actually plays into insurance from a 10,000-foot view. And so insurance is just a form of risk management that you can use to hedge against risks. So basically, for a price, for a transfer, you transfer the risk of a really, really big loss from one entity to the other, And this pooling of risk and a large risk is how you get stable, measurable characteristics. Health insurance, by its very design, pools this financial risk across a large group of people. So the people that are healthy are willing to accept that the cost of the insurance is more than they would have to pay in health experience. And they're willing to accept that small loss month to month or at the end of the year to hedge their risk of a major loss. And then all of that excess money is used to fund the costs of high-cost folks. So Medicare is one of the largest health plans in the world with more than 50 million beneficiaries and getting bigger rapidly. And in that plan as an insurer, 1 in 4 choose Medicare Advantage. And HCC risk scoring is critically important for Medicare Advantage. Realize that right now, risk has been operating in the background for decades and been scored in the background for decades that many of us may not have known or been aware of, but it's rapidly becoming more important as we have disruption in our payment system right now. We're all familiar with this picture. Basically, it's telling us that moving from now into 2018, only a very small percentage, 10% or less of patients are going to be in a purely fee-for-system world, which 10 years ago, that was virtually 100% of Medicare patients. And what Medicare will be paying is increasingly linked not just to quality, which is considered category 2, but actually to outcomes and then all cost of care when you get into payment categories 3 and 4. Another way of looking at that is like this. So category 1, pure fee for service, started out at 100% back in 2010 and is going to drop to less than 10% moving forward. The light blue and green lines, which are the payment categories that correspond to outcomes and to the providers and payers taking on a portion of the risk, are rapidly rising. So again, quantifying that risk that you're being paid for in this system is critically important, both at the provider level and the payer level. Now this is kind of a provider way to look at it. A more clinical physician view of the world way to look at it is just to consider population health. Population health is the process of identifying your patients, stratifying them, engaging those strata differently, intervening when you need to, and then remeasuring and repeating. And that is how our clinical brains really have come to understand risk. We know that not all patients are the same, but what's different is that we are choosing and increasingly bringing different tools and personnel to bear on different groups of patients. And all of that rests on the concept of individual and collective medical risk. And so that's the background of where we're starting from. Now I realize to some degree that every physician wants to believe their patients are sicker, and that is true. Everyone has a very instinctual level, intuitive level of your population and the 20 patients that are the sickest that you spend a lot of time on. It's just hard out of a panel of 1,500 or 2,500 patients to really add that up at an intuitive basis and compare it to Dr. Miller's patient panel or Dr. Wergen's patient panel, et cetera. And so this risk adjustment is really the way we do that. And I realize that we're talking today and focusing on Medicare HCC risk system because that's what is used for Medicare Advantage and for ACOs, right? Which are a Medicare shared savings focused program. There are other ways to identify and quantitate risk, however. This is just listing some of them, and you see that CMS HCC is listed there. There's Johns Hopkins has 2 models that are built up on each other. There are multiple, and each one of these has benefits and risks, and we're not going to get into the weeds on any of them. Besides to say that many care management systems do use Johns Hopkins ACG risk system, and I'll touch on that briefly. And lastly, you realize that though these are quite good, these risk prediction systems are not perfect. So you see for HCC, and this is old data I think from the 11, 12, 13 era. They accurately predict about 58% of future ED visits, 67% of hospitalizations, 74% of hospital readmissions. And again, it's 5-year-old data, but at that time, and updated, that R-squared value says that HCC accurately predicts about, now currently it's up to 18% of the individual variation in cost from one year to the next. So I mentioned the Hopkins model, and this is just to kind of give you a comparison that we're going to work against. So Hopkins takes a little different approach. They are wanting to look at the expected resource use, which is similar, but they break it down into 32 aggregated diagnosis groups, which are clinically meaningful, but they're not tied to diagnoses specifically. And those 32 groups are combined into more than 100 exclusive, mutually exclusive categories that they conceive of represents disease burden. And here's just an example of some of those categories that they use. So they use, okay, a time-limited minor problem, a time-limited minor infection, time-limited major problem, and a chronic medical problem that's stable or unstable, a chronic specialty problem related to eye, related to orthopedics, et cetera. So you kind of see it. So their system is more about describing the patient's clinical situation than it is the diagnosis or bucket of diagnoses like HCC. But I thought that was a good comparison just to be aware that there really are multiple systems that are in use now. So this concept all makes sense. So it's easy, right? We just figure out how to accurately predict who's getting sick next year and pay more attention to them. That's pretty simple, right? Well, let's explore the RAF, HCC RAF system and talk about that. HCC RAF stands for, or HCC stands for Hierarchical Condition Classification, and RAF scores for Risk Adjustment Factor. So right now we're in version 22 and realize that usually released in the fall, not in the final rule, but similar timing to the final rule, they release a yearly update to the HCC scoring system. Right now, we know in ICD-10 there are 64,000 some odd specific diagnosis codes. HCC encompasses about 8,800 of those codes, both acute and chronic conditions. And it's interesting that there's a fair bit, but not precise overlap to the inpatient DRG system. So about 75% of those codes currently captured in the 79 buckets of HCC, about 75% of them are DRG major conditions or comorbidities. The original purpose of HCC for care was originally Medicare Advantage. So digress a minute, because SERPA is an ACO and not a Medicare Advantage plan, but you may have Medicare Advantage plans in your area, and this is critically important for them. Medicare Advantage, each patient's HCC score rolls up to a population risk score. And that patient risk or population risk score defines precisely what the dollar amount per member per month, per beneficiary per month, that Medicare pays that Medicare Advantage payer for the next year. And that does promote fair payment. So if you've got a Medicare Advantage plan, each patient is being paid appropriately based on their average intensity or use of resources. And it keeps an individual payer or insurance from adversely selecting for the chronically ill. This is how you adjust against kicking out all the really sick people because they take a lot of time and they cost you too much money. So there's a number of data sources that feed into the HCC system, and realize this is diagnosis driven, but there are only these five sources of diagnoses that lead to this: hospital inpatient principal and secondary diagnoses, hospital outpatient diagnoses, physician visit, so Part B diagnoses, and clinically trained non-physician personnel, which is defined by Medicare. It does not involve all of our ancillary personnel, but it does involve psychologists, counselors, social workers, and podiatrists. Here's a view of ICD 9 to 10. So in ICD-9, actually 24% of the 14,000 diagnoses codes were included in HCC, and now it's down to 11,000. But that's just because the universe of codes expanded so dramatically. There are a small number of diagnosis codes that can be mapped to 2 different buckets, but that's unusual. Only 68 out of more than 7,000. So the first thing to realize for your HCC risk scoring is all the diagnoses applied for a patient across sites of service, inpatient, outpatient, physician office, and selected non-physician ambulatory providers. All those diagnoses are captured on a Medicare 1500 through the billing system, and that collection starts January 1st and ends December 31st of every year. And so the first fundamental concept is that risk points you get, and we'll touch on this more deeply in a minute, is reset and starts over every year. And so I know for attribution to an ACO, it's critical you see your patients every year. For their risk score, it's critical that your patients are seen each year, or else their risk score for codes that were not used in the last year, those risk points just drop off and disappear, even though the condition and the intensity and the resources you have to bring to bear to treat that chronic illness clearly hasn't gone away. So in addition to diagnoses, there's also some demographic factors. 24, kind of a matrix where there's gender and age, and there's 24 age, sex cells that are unique and mutually exclusive, of course. There's an indicator for Medicaid enrollment, and this is a poverty indicator. So even a single month of being officially in Medicaid gets you additional Medicaid risk points for the year. And then there's a disability status indicator. So with these factors, diagnoses, demographic factors, Medicaid status, disabled status, all of those go to 79 buckets. And each patient can be assigned to none. Everybody would get points for age and gender, but can be otherwise assigned to no additional HCC buckets, 1 or more than 1. And if it's more than 1, there are interrelationships among certain diagnostic buckets that give you bonus points. So basically, those 79 buckets allow you to individually predict, to the best of our current science, the cost and resource use, and therefore price, tens of thousands of different clinical profiles using just about 200 parameters, which is a fairly impressive bit of actuarial science. So here's another way to see it for those that are visually oriented. So into HCC, you have demographics, you have disease, you have multiple chronic diseases in the light blue. In the purplish color, you do have disease interactions that suggest that things are more severe, such as, we know that the patient has diabetes, it's poorly controlled, and bad heart failure. It's more than the sum of the parts, right? The diseases interact and make the patient even more risky and sick than average, and HCC recognizes that. And then this is prospective in nature, so it's moving forward. It's things that happened this year are used to predict expense and for Medicare Advantage directly influence payment for next year. There is a slightly different model for new enrollees versus existing enrollees. So if you turn 65 and sign up for Medicare, obviously there is no data related to your diagnoses from the prior year when you were 64, right? So for that first year, for new enrollees, they essentially only get the risk characteristics that come with age, gender, disability, Medicaid status. So the first year you're in Medicare, your risk score does not reflect your reality, but then starting, upon the time you turn 66 moving forward, you have the opportunity to accurately collect that risk. So there's another important reason to meet all of your patients who turn 65 with a birthday card and a letter from your office saying congratulations. Let's be sure to have the chance to take great care of you this year and let us see you. So here's a schematic again. We've referenced it, but this is a way to put it visually. So This is based on ICD-9. Obviously, we're in ICD-10 now. So ICD-10 codes, more than 64,000, are lumped into several, multiple hundreds diagnostic groups. So basically, every ICD-10 code is in one diagnostic group. These broad groups of diagnoses are then clustered into a condition category, which are similar diseases, like all the things that describe types of heart disease are clustered together. And these are related both clinically and related by cost. Then, so those efforts happened in 92 to 97, leading into late 90s. Medicare imposed a hierarchy, and they said we're going to take these condition categories. Originally, there were 189 of them, and we're just going to make a hierarchy ranking of all of them. So essentially, it would go from very highest ranking factor, therefore most expensive, down to the least. And so that gets you to hierarchical condition class categories, HCCs. And then in 2004, this HCC system was kind of fully fleshed out when Medicare removed the HCC categories that really didn't seem to have anything related to cost for the following year. And they used their claims data statistically looking backwards over 5 or 7 years and said these particular categories don't seem to predict anything for the following year or had a negative correlation. So you had the fully realized Medicare HCC system in 2004. It had a major upgrade, and it somewhat a change of the statistical model in 2009, but short of that, it's just kind of tweaked yearly. Well, I mentioned the hierarchy. So how do these hierarchies work? So again, this is using ICD-9 codes, and in the next talk, where we're going to get much more tactically and talk about very specific codes and individual HCC buckets we will explore, all of that will be provided for you in ICD-10. But this is a good conceptual slide that Medicare has used in lots of venues, just to say, okay, so in HCC, there were basically, at the time, there were 4 buckets for coronary disease of different types. And they're hierarchical. At the very, very highest, most riskiest or most cost resource intensive is acute myocardial infarction. That means, upsloping ST segment on the EKG, positive enzymes right now. So they are actively infarcting, or Medicare is now defined, you can call a patient an active MI for 30 days. After 30 days, it's no longer an acute MI. Well, the next bucket below that would be unstable angina or other acute ischemic heart disease, and that makes good sense. Someone who's got multi-vessel inoperable disease with active angina, waxing and waning, they're pretty darn risky, and you're just waiting for bad things to happen. The next bucket, HCC 83, would be history of MI, old MI, or angina, meaning stable angina. And then lastly, the least risky of the coronary artery disease HCC buckets would be just simply the presence of CAD. They haven't had chest pain, they haven't had an MI. For some reason, they had a heart cath, they had a CT, calcium scoring. Something happened that let you have insight that this patient has chronic CAD, or they have some other, mild ischemic heart disease. Suddenly their EF starts dropping a little bit. So that gives you a sense that there's a hierarchy that's logical and clinically arranged, and you can assume when you start seeing individual numbers that the risk points for each of those ascends in each family of HCC buckets. So there are realized multiple HCC models. The HCC model that really is most familiar and most of you want to work with all the time is called the community model. There's also, however, an HCC PACE model for those in the comprehensive primary care of the elderly programs. There's a ESRD model, both with a post-transplant and or on dialysis. There's an institutionalized HCC model for those living in nursing facilities. There's an HCC model for those that are fully disabled. And then lastly, there's actually an HCC model corresponding to prescriptions. And so, again, you back up 5,000 feet, you can kind of see that each of those is kind of a unique population, and therefore the diagnostic buckets, which are the same bucket. So if you look at HCC bucket 82, whatever that may be, in the community model, it's also bucket 82 in the ESRD model, but it's arranged differently. It might have somewhat different diagnoses in it, et cetera. So those models were what Medicare derived statistically to say the populations were different enough they needed slightly different predictors for next year's cost. Now the normalization factor is the variation between predicted cost and actual cost. So you say for the community model, looking backwards from the known cost of last year, because we have all those bills in, so the known cost of a patient or population for 2015 compared to what was predicted based on their HCC risk model in 2014 is 99%. That's pretty good. Now, obviously, it's very powerful for large groups of people, like an ACO population with 15,000 beneficiaries. It's clearly not that level of accuracy if you're talking about an individual, but it's still a good rule of thumb. The ESRD model for transplant actually slightly over-predicts cost by about 5%, but the others are, I mean, it's pretty darn good. So let's look at a vignette to kind of get a sense of how this flows. So Mrs. Smith is 76, lives in the community. She is not on Medicaid. She is not disabled. She does not have end-stage renal disease, and she's not in a facility. So she has 8 chronic conditions. We all have those patients, or eight things diagnosed. Some of them are chronic. The sprains at the bottom is obviously not chronic, but it was a diagnosis used this year. So those diagnoses fall into 7 different diagnostic groups. And here's a way to look at that. Again, using ICD-9 for simplicity and for using kind of standard slides that Medicare has used before. So you see those diagnoses: AMI, angina, chronic bronchitis, emphysema, unspecified CKD, and unspecified renal failure. So you realize there was a sprain. Okay, sprain doesn't track to that's a diagnosis, but it does not track to a ICD-9 or 10 diagnoses within a chronic condition bucket. So that one drops out. Now you see your diagnostic groups: AMI, angina, emphysema, and chronic bronchitis both roll up to the same diagnostic group. Chronic renal failure, and then unspecified renal failure. So maybe that was acute. So then you apply a categorical condition to it, and it breaks down to 4 because renal failure chronic and renal failure unspecified really roll up to the same concept in terms of clinical intuition and cost prediction. And then you apply a hierarchy there, and you see that, and you wind up with this patient qualifying for 3 HCC risk buckets: 81, 108 for COPD, and 131 for chronic renal failure. Now you notice there were two here for acute MI and old MI or angina. They're similar concepts, 81 and 83. Well, the hierarchy idea is that you get the risk points for the highest risk in a given family of buckets. And so the risk for acute MI is higher than the risk for old MI or stable angina, and therefore you keep the higher risk. The lower risk bucket in the family drops out. Here's another way to look at the predictive power of HCC. And again, this is an older slide from 2011, but it is instructive. So just look at the ratio of predicted to actual. So if a patient had no HCC categories, it predicted 95% of next year's expenditure, looking on a backwards-looking basis. 1 to 3, slightly over-predicted. 4 to 6, slightly over-predicted by 1%. 7 to 9 different HCC categories, and 10 or more, slightly under-predicted the cost. But the power of this is that things that we know and are in our control to diagnose are very effective working forward prospectively at predicting costs and allowing you to bring different tools to bear. So another way to look at predictive power, this is just diving into cancer. So there are a number of HCC buckets that attribute to cancer, and we'll get into more details on that on the next on part 2 of this conversation. But just looking at cancer, so you say if a patient is in the lowest decile of cancer risk all the way up to the highest decile of cancer risk, for each of those deciles, it still pretty well predicts costs for next year. So in the middle, again, the pattern is similar. So in the middle, it slightly over-predicts, and for lower risk things, it slightly under-predicts cost, and that pattern remains consistent. Okay, so we've talked about the HCC buckets, and we've talked that each of those has a weighted risk factor that's usually a decimal, and then you add up. So you add up points for age and gender cell. You add up the risk points that track to each HCC bucket. There's 79 of them. Then you apply any multiplicative factors for diagnoses that interrelate with each other. You get kind of a secret sauce. And then you wind up with a total number. So the RAF score is the sum of all the weights plus the age, gender, cell, plus the Medicaid adjustment and disability adjustment. And then that RAF score is applied by CMS's base payment rate again in Medicare Advantage, and I promise to bring this back home to ACO situation. And that says what Medicare is going to pay for that member every month for the next year. It's important to realize that a risk score of 1 represents the average Medicare risk, which is about $7,500. So the average Medicare patient, if there's any such a thing, has a risk score of 1.0, and that is considered to cost to care for that patient $7,500 a year. So your monthly per beneficiary per month cost is a number if you divide that by 12. So a RAF score more than 1 means the individual is more likely to have costs incurred the next year, and less than 1 means they're less likely to incur costs, or they're likely to incur costs less than average. So realize to some degree that HCC RAF score is not exactly the same as clinical risk or risk of bad medical things to happen. Typically tracks to the predicted cost. Now, cost is a pretty darn good, index of risk and for bad things being happen, especially hospitalizations and interventions like cabbages, etc. So the HCC RAF score identifies a patient's health status based on the best of what is known to Medicare. And if you have a lower RAF score, it either means the patient in front of you or the population you're dealing with is healthier than the average Medicare patient, or it means any or all of these. It means that the coding for the patient was incomplete or non-specific or unspecified, or significant conditions were just not coded in the last year, and so as of December 31st, those risk points expired. It may mean the patient has not been seen in the last year. Therefore, none of the patient's risk points besides age and gender are now captured. Or if your charts are coded by a coding service, it means your documentation of each visit didn't allow the coder to capture what you described as actual diagnoses. Remember, on the ambulatory side of the world, we're not allowed to diagnose based on suspected, probable, or rule out. So if you get a lab back and a blood sugar is 160 fasting, and you say high blood sugar, rule out diabetes, a coder cannot officially diagnose that as diabetes. You have to say this is diabetes. So those are the only ways to interpret a low HCC score, and that then gives rise to obvious action plans of how to take this work on to the benefit of your patients in the ACO, which will be part 2 of this conversation. So what are the implications here? The implications are, overall, it does slightly overpredict the healthier, therefore least costly beneficiaries by a couple of percent. And when you're dealing with 50 million beneficiaries, a couple of percent is a lot of money. It also slightly underpredicts the cost of the most costly beneficiaries. And the way I use that clinically, once you've kind of figured out how to track and have visibility to HCC scores, if you see a patient in front of you or a population you're looking at, and you have the score and it's 2 or 3, you always think, well, actually a bit worse than that. And if they're healthier than average, so your number is 1.0 something or less than 1, you just kind of think, well, that maybe is a slight overprediction. Maybe this patient's future is a bit better than this suggests. So theoretically, this can benefit a plan to have a relatively high proportion of low-cost enrollees, and disadvantage plans that have lots of high-cost enrollees, but then realize that it regresses to the mean. Because bad things happen, patients show up in hospitals, the hospitals submit diagnoses, they're definitely going to do what they do to get paid, including all of the major comorbidities, right, to raise their DRG, to improve their payment. Those diagnoses get captured, and so the solution set for those that are sick gets increasingly accurate as things happen. It also affects, for Medicare Advantage, what they're paid, so everybody is interested in coding accurately. For the ACO, it affects your average cost and utilization metrics, and therefore it again regresses to the mean as you're encouraged and want to have your cost metrics accurately reflect and get credit for the illness of the patients you're taking care of. Lastly, realize sometimes my partners want to think that this HCC thing is really just about Medicare. And I guess I have to say, and we partly started that looking at the Johns Hopkins risk system, which is more directly pointed at clinical risk, if you will, but also a bit less actionable, I think, in terms of the individual physician's ability to influence. Risk adjustment touches everything. And what I mean is, for Medicare Part A in the hospital, DRG assignment, major comorbidities directly affect risk. For Part B ambulatory care, the RAF score and the various models are affected by risk. Medicare Advantage is very specifically affected by risk. For the Part D pharmaceutical benefit, that's adjusted by HCC prescription risk model. For the Medicare innovation models, CPC, CPC Plus, and MSSP, your quality and cost utilization metrics are risk adjusted. And that's the secret and the home run to understanding this concept in the ACO setting, is when you get back at the end of the year, you know what Medicare predicted you would spend based on the risk of the population from last year's coding. You see the patient through a year of service, all sites of care. 6 months later, you get Medicare who tells you this is what we expected you to spend, this is what you actually did spend, and if you saved more than 2.5%, we return some of it to you, right? That's how MSSP ACOs in general work. That prediction of what the patient's going to cost and the calculation of what you actually spent, both of those are adjusted based on the patient's and the population's HCC risk. So moving forward, in terms of MIPS, starting in 2019 based on 2017 data, your average return or discount based on your quality utilization is risk adjusted using HCC. And then even past Medicare, private payers, every private payer has a risk model. And it's been going on for years. Blue Cross Blue Shield uses one called Truven. that I've had a chance to kick around a little bit before. It is black box math. They don't tell you really how it works. You often don't see your risk assignment that Blue Cross knows, but they're doing it. And virtually every private payer has a risk model they use, and it's partly how they predict, you know, what their expenses and reserves are going to be. It's also used in network selection. If Blue Cross is just getting beat up in their cost of coronary acute MI and CABG care in the Kansas City market, and they decide part of the way they're going to save costs because they can't raise the premium is they look at risk scores and outcomes, and they decide to trim those cardiovascular surgeons that do the most CABGs that have the most bad outcomes. So this is used by private payers for all kinds of things. So risk adjustment and risk calculations touches virtually every patient we take care of. So I've mentioned that this plays into Medicare Advantage. Again, that's just a useful model to understand this. So if a patient has a score of 1.5, and that means an expected cost of $11,194. So if average cost is $74.63 per year, and they're 50% riskier than average, literally what that patient would get paid for an MA plan is 50% more than that. If a patient's risk score is 0.8, that means it's adjusted downwards to 0.8. So the expected cost of a patient with a 0.8 risk score is 20% less expensive than average, or $5,970. So if you're a hardworking group of clinicians and nurses and operational managers in an ACO that have pledged together to collectively care for a population of patients, and your risk score overall is 0.92, which is a very, very typical risk score for an unselected kind of ACO that is de novo, has not been focusing on this. That means that the average cost of your care in that ACO is being downward adjusted by 8%. And then when your costs come in at the end of the year, it's compared to that downward adjustment. So here's the timeline for MIPS, just again pointing out that all of these things here, your resource use and your quality, both of these top two categories under MIPS, are risk adjusted moving forward. And that leads into this for MIPS. Starting out earlier in 2019 is this light gray line saying that, you know, some of the folks will take up to a 4% decrease on Medicare payment, and the money is going to get returned to those who did better. Well, that is budget neutral, essentially, taking from Peter to give to Paul. How much is available is risk adjusted, and how well you did is risk adjusted. And you can see the slope of this as we move towards 2022. The slope of this line gets ever stronger. So the risk you run not paying fairly close clinical attention to the concept of risk scoring is if you just tread water and your peers continually get their risk scores rise over time to reflect their actual population, you may the first year wind up here, but then your patient experience slides backwards in negative territory as your risk score stays static. So the take-home slide for the day, quality and utilization in an ACO are risk adjusted. And here's kind of how the math works. So consider kind of the total cost of care looking backwards. For risk score, it's 1.06. If the made-up number they're expecting a cost of $800 per beneficiary per month, and your population RAF is 1.06, that means actually for you, your expected spend is $848. And then if you actually spent $800, the interpretation is you saved 6%. You saved $48 PMPM. And between you and me and the fence post, a $48 PMPM savings per beneficiary is a huge savings. That would lead to money being shared. Conversely, if you're looking at a RAF population score 0.9, that means your patients are sicker than expected. You should not have to spend as much money to take care of them. And so your ACO expected per beneficiary per month expenditure drops to $720. If you still spent the exact same amount, you still spent $800 per member per month to care for those patients at the end of the year, the interpretation is you actually spent $80 more, or 10% more, than you should have or needed to. So this just highlights that you spend the same $800, you don't change what you do, and the interpretation of what that means changes dramatically from 6% savings, we have money to share, to 10% loss, and that makes a big difference. So that's where we are with the end of the slides. We've got about 10 minutes for questions. I'll be happy to answer, and let me turn it over now to Jolene.
If you have any questions, you can ask those questions. I will try and unmute all of you. So, if you have any questions, please ask.
And so this, I don't know how much this makes sense to that, but that's like a 0.01 increase in underscore.
Sorry, I'm not able to hear or understand whoever's speaking. If they can type it into the chat box, I will read it out loud.
As someone just having a conversation over there.
Sorry, that's me.
Okay, I did get a question. Does December 14 at noon still work? Oh, sorry, that was Jolene. We'll talk about that.
Okay.
Sorry, didn't realize that was to me. Okay, any questions? I know this still was a little bit conceptual, but hopefully you got a sense of the importance of this, and we will get, specifically individual physician and clinic oriented what to do about this with this knowledge now at the next time.
Hey, this is Logan. I think I just got unmuted. Logan Pritchard here. I did have a couple questions. First off, I think you covered it in your talk. When we first started looking at these HCCs, we were concerned that if we did a specific diagnosis and then another specialist of some sort did a less specific diagnosis, would that interfere or end up trumping our more specific diagnosis? It sounds like the answer to that is no in the way that the HCCs are built. Is that correct?
Yes. Consider the buckets that relate to heart disease. So this is the hierarchy step. If you have diagnosed coronary disease with unstable angina, which is the second height, because the patient's not infarcting in front of you, but they have unstable angina or active angina, and they see the cardiologist, and the cardiology diagnoses something less specific, which always means less risk.
Lower bucket, right? Okay.
Like CAD NOS.
Right.
The higher bucket, regardless of who coded it, is what contributes to the risk score. So the risk score is with a patient-specific focus, not a provider-specific focus.
And that's what I thought I understood. I just wanted to clarify. You mentioned Blue Cross Blue Shield and their Truven program that they use to calculate risk and being a black box and not sharing that with anybody, which somewhat makes me concerned because we do have a fairly strong contract with Blue Cross Blue Shield. It always makes me nervous that they get to the end of the year and say, they hold the calculation and, the skeptic in me says, oh, you scored this, we don't share any money with you, and we have no way to verify that. Do any of the other risk models do a fairly good job of predicting that? Could we use that as like, hey, you say we score this as risk, but this says we score this? Is that a reasonable thing to look at?
Well, two questions, two parts to your question. The first is HCC is very specifically focused on Medicare age older than 65.
Right. Okay.
It is less statistically valid. You start getting variations of expected to predicted cost as high as 25-30% with younger people. So HCC does not work with younger population, especially below late 40s to 50s. It breaks down.
Okay.
The Johns Hopkins model is a whole population model. When I was Chief Quality Officer at the ACO in Wichita, we had HCC, of course, but we also used Johns Hopkins across the whole population. So you can get that information, and you can kind of have an understanding of what your risk is for each patient in your population. I don't think, to the second part of your question, though, I don't think that helps you with any of the individual payers.
Okay.
In general, they still know what they think they know, and they're more or less willing to share their data depending on the situation. So that is always a worry, and certainly very legitimate. But I think once we kind of raise our vision to the power of what we document leads to what we diagnose, which leads to what we code, and when you apply risk and severity concepts to that, it does leave you motivated to code very specifically, as specific as possible, and to be sure that the important things are done every year. Then you know, even though you really only have data for Medicare per se, you know that is reflecting through your whole population.
The last question I had was, in designing these talks and thinking about them, would it be helpful to, I don't know how much information about our organization has been shared with you, like, you know, would it be helpful to sort of discuss the generals about what payers we have contracts with and what they look like, or is that ancillary and you don't really, for what you do, you don't think that would be helpful?
Well, I always would like to have deeper insight into your all's challenges and what's working and not working, and that's something that we can get on the phone with Jolene and talk offline about. Yeah.
Yep.
Yeah, I'd be happy to take any specifics I can learn specifically into the presentation.
Okay, awesome.
Okay, we got a question from Edward Disco. Does each diagnosis need to be referenced twice a year? No. Nope, a single diagnosis used once a year means it's captured by Medicare and it counts for risk scoring. Question.
This is Jolene, and as we understand it right now, for the Blue Cross Blue Shield, they use CRGs, and we use the TRAO system. Our Blue Cross Blue Shield of Nebraska uses the TRAO system, and in that system where they need to have it that diagnosis identified twice, whether it is through 2 visits or it's through the visit and then a pharmacy, a drug being filled or something, they need to have it unless you are a hospital. That is how Blue Cross Blue Shield has explained it to us.
Oh, good, thank you. That's a specific approach your Blue Cross carrier is taking, but that makes sense.
It does? I'm not sure that makes
sense. It does. So they're saying, basically they're saying, okay, compared to Medicare, for younger, healthier people, we believe that a single diagnosis used once maybe doesn't reflect a real condition or predict severity or cost. And so we want 2 data points, two points to make a line. We want 2 data points to convince us this is real. And for something like heart failure or hypertension or COPD, the diagnoses and a prescription paired to that, at that same visit, will probably get you that type of recognition. You would just have to think about things that don't have many diagnoses, like chronic kidney disease. So saying a patient has stage 4 chronic kidney disease almost always in most risk models has risk, but there's not a prescription for that specifically. And so that patient, you'd want to be sure someone coded it twice. And if they're not in the hospital and they're not seeing nephrology, you want to be sure you got them in twice. Things like cancer, things with the very highest risk, ulcers, like dialysis, those almost always are seeing specialty physicians which have multiple visits a year and code those things. Got just a few minutes left. Great questions. If you all do have other questions, forward them to Jolene. I'll be happy to address those as we start the second part, whenever that is.
We're looking at December 14th as our next webinar for part 2 of this. And it will again be 12 to 1. So if you want to mark that on your calendars, I just want to make sure that gets out there so that we will do part 2. We'll take and we'll look at some of Logan's suggestions and maybe get into a little bit more detail. Anybody else have any questions? If not, I would like to thank Dr. Mills for presenting today and look forward to his next presentation.
Thanks so much. I enjoyed talking today.
Thank you.
Thank you.
Thank you.